Hydrocephalus or water in rain. In Arabic it is istisqa al-mukh. At the end of the lesson should be able to define hydrocephalus, diagnose a case of hydrocephalus, summarize the management plan, describe ventricular shunts, and describe complications. Hydrocephalus definition. It is excessive accumulation of CSF associated with progressive ventricular dilatation or increased intracranial pressure. What's the pathophysiology of hydrocephalus? Disorders of cerebrospinal fluid production, which is rare, as choroid plexus papilloma. Secondly, obstruction of the CSF pathways. This can occur at the ventricles or arachnoid villi by tumors, hemorrhages, congenital malformations, and infection can cause this obstruction. Disorders of cerebrospinal fluid absorption. Conditions such as the cerebrovenocaval syndrome and the cerebrovenous sinus thrombosis can interfere with CSF absorption. What is the clinical presentation or symptoms of hydrocephalus? In infants, this depends on the age. Infants below 2 years of age. Symptoms usually relate to increased intracranial pressure as excessive irritability, lethargy, or vomiting. In older children include headache, nausea, or vomiting. Symptoms tend to be more common in the morning when the intracranial pressure is higher after having been recumbent overnight, along with decreased ventilation, retained CO2, and increased cerebral blood volume from vasodilation. Rarely visual defects related to severe papilledema, double vision from abducens nerve paralysis. Signs of hydrocephalus in infants up to 2 years of age. Macrocephaly and progressive increase in head circumference, bulging anterior fontanelle, sunset appearance of the eyes. Normally, the upper eyelid covers 1/6 of the cornea. In sunset appearance, the upper eyelid will be covering even the sclera will be obvious. Upward gaze palsy, bradycardia or apneic episodes in more advanced cases, and failure to meet normal developmental milestones. In older children, papilledema, abducens nerve palsy, failure to meet normal developmental milestones. What about the clinical course of hydrocephalus? It could present as acute syndrome, acute hydrocephalus, with sudden obstruction of the CSF pathway. Can be followed within hours by acute dilatation of the ventricular system proximal to the block, causes rapid and progressive rise in intracranial pressure if the cranial sutures are closed. There will be transepidermal CSF migration as in the CT and the MRI below. Arrested hydrocephalus or compensated, there will be no transepidermal migration of CSF. It is a state of equilibrium between cerebral ventricles and the brain parenchyma. The size of the ventricles remains stable, no new neurological signs, compensatory adjustment if the ventricular obstruction is incomplete and slow. In this case, we might not insert a shunt, just follow up of the occipitofrontal circumference or for signs of increased tension.